Hello, Don here. Welcome to Podiatry Practice Mastery, where we're here to help you bring your practice to the $2 million mark in personal production. So I'm going to go over a couple of my daily tracking sheets. I haven't done these for a while, and so I'm gonna kind of focus more on maybe my least valuable patient and some of my most valuable patients, and I'll probably do some other ones as well interspersed. But the reason is, I think if you can reduce the least valuable patient, the amount of least valuable patients that you have, and increase the most valuable patients, that's one of the easiest ways. And if you think about it, the least valuable patient isn't really the patient that you saw, it's the open spot in your schedule that you didn't see anyone. So I just want to, this is something that I don't typically track. I track the number of patients I see each month and things like that. But as I've been thinking more about it, really the least valuable patient for us is the one we don't see. So we have open spots in our schedule. So maybe even tracking that on a daily basis, how many you see and what was the potential. Let's say your potential each day is like for 25 patients and you see 25, okay, that's 100%. Just give yourself a number. But if you're seeing 20, then there's 5 open slots, and that's really the factor that's being lost. Okay. Let's go into this. First patient was a 39-year-old man. He had got a fungal kit, and he was status post-wart and probably a nail sample, so he got the UV light and the shoe spray, and I'll be seeing him back in 3 months. Next was a right plantar fasciitis pain, 41-year-old man, and I did an ultrasound today. And then based on the ultrasound, he set up 6 sessions of shockwave, and at the 3rd shockwave session, we're going to do an orthotic for him. So he would be one of my most valuable patients of the day. This gentleman, he works in the film industry, and he's traveling around a lot. And it's interesting. So I think some patients that they want to get like VIP treatment. And so in his specific case, since he travels so much and now is a lull time because of the winter, I said, hey, if you wanted to like front load your shockwave, you can. So theoretically, some patients I do it every 72 hours or every 3 days. And so this is what I did in this specific gentleman. I said, we can do some quicker every 3 days, some a little bit more spaced out because of his travel schedule. Next patient was a 69-year-old female. She had an orthotic adjustment. I put a metatarsal pad. Actually, I didn't put the metatarsal pad in. When I made the orthotic, I asked for a dancer's met pad with a cutout under the third met head, but they put it out under the first met head, which is a traditional dancer's met pad. Maybe they just didn't read my little writing, or maybe I prescribed it wrong. So this would be one of my least valuable patients. Come back for an orthotic adjustment. I try to get these orthotic adjustment patients in my 10-minute slots. And then I also did the calluses and the nails for this patient. This was not a nail care, but I sometimes just add that on because it's something that I can do and she's already there. Next patient was a 63-year-old man, number 3 out of 6 for plantar fasciitis for shockwave. Next was a 28-year-old female for a left foot sprain. We just did an x-ray, no follow-up. Next was bilateral a cortisone injection and did PT. Now this is a patient. She is going to be a nurse practitioner, finishing up her studies. Very busy, doesn't have time. She's already had 2 cortisones. She wanted a 3rd one, but I showed her her ultrasound again, and she really needs shockwave. So what I did to get her through her academics, I did a cortisone, which I don't normally do. I will see her back in 10 weeks when she's done with her clinicals, and we're going to set her up for bilateral shockwave because that's really what she needs. And so we actually schedule those for 10 weeks out. Next was a 24-year-old man, bilateral IND. And now this gentleman, he had so much swelling around in like granular tissue around the medial and lateral sides. I'm going to stage his procedure, meaning sometimes if I can, I'll just do a matrixectomy. But I think with all that extra tissue in there, sometimes it's hard to see and make sure I put we use sodium hydroxide in the right spot. And so for him, I'm going to do it staged. So I do this, and then I see him back in 3 weeks, and I'm going to do a matrixectomy bilaterally. So it's kind of a staged procedure. Next patient was a 57-year-old female. She got the Lamisil booster, and she also had an ingrown toenail, and she wanted a matrixectomy. So we were able to do the office visit for the ingrown, the matrixectomy procedure, and we did the Lamisil booster for her. And I'm going to see her back for the matrix follow-up for a 10-minute slot in 3 weeks. Next was a 70-year-old man. He had some neuropathy, and so we did the EBM neuropathy, and I'm going to see them back in 3 months to see how they're doing. Next was a 63-year-old man with left Achilles pain. He has a calcific Achilles tendinopathy, and he had been seen by another doctor, and he is a busy truck driver and doesn't have any time. This kind of seems like this was the theme of the day. And so what he needs is shockwave. And so I did an ultrasound. I did an x-ray for him, no ultrasound. He did have some anterior ankle pain as well, so I did an anterior ankle injection, and I recommended this success into shockwave, so he probably needs to talk to his wife. But I think that's what he's going to be doing, because that's really the only thing that would get him better. He had been recommended surgery by another doctor, but he just doesn't have time for that. Next, with a 35-year-old female, I did cantharidin, see her back in 2 weeks. Next was a chill. This is kind of an interesting patient. She was a 42-year-old female. She had been seen in the urgent care 3 times already for some discoloration at the distal tip of her right great toe. She had recently had abdominal surgery 6 weeks ago. Now, this was kind of a complex one because she was given 2 different types of antibiotics, and she came in wanting a third. I got an x-ray. Everything looked fine. It looked like chilblains or some cold injury because it's been so cold here in New England. That's what I think it is, because it's not getting worse, or it could have been toenail injury because there was some black and blue. But she said she wasn't outside because she was recovering from surgery. But I also find that some patients, if they're just not as active and it's colder in the house, they still can get even this chilblains inside of the house. So this was a unique one. I did put her on an antibiotic just because basically she asked for it and she was concerned about MRSA, which I do not think it is. But I did that, and then we're just going to monitor that. Next patient was a 27-year-old female. We did an I&D, no follow-up for an ingrown toenail. Next was a gentleman. He had a 60-year-old male. He had a right MRI follow-up due to a cavus foot. And this gentleman has bilateral cavus. He developed peroneal tears on the right side. That's what the MRI showed. He had previously just been doing fine with orthotics. I talked to him about either an ankle brace or an AFO or surgical repair, and he opted for the surgical repair, so I'm going to refer him to one of my surgical colleagues that can do that. Next was a third-digit toe ulcer. She had an ulcer. I did ulcer debridement. See her back in 2 weeks. Next was an orthotic. An 82-year-old female had an orthotic. It was too high in the arch, so I heated it up with my heat gun, and I dropped down the arch. Now, this was also my least valuable patient, but because of the orthotic adjustment, I could bill an office visit, but she was also status post-flexor tenotomy, so she had recently had a flexor tenotomy, so that she was still within the post-op global for that, but because of the orthotic adjustment, something else, we could do that. Next was a 22-year-old female. She came in status post-matrixectomy, and she had a big granuloma on the side even after the matrix, and I trimmed that down for her at the matrix follow-up. She's going to come back as needed, or if it comes back. Another patient was an 80-year-old female that had some metatarsal pad. I added one of these blue met pads we have here onto her insert in her shoe, and she's going to come back in about 3 weeks to see how that's doing. And I did tell her, we got x-rays, and if that works, we'll transition her to a custom orthotic. I have a 55-year-old female, status post-bunion with x-rays. So once again, post-ops tend to be least valuable patients, so I do not do a lot of surgery. I'm seeing one of my buddies is out on paternity leave, and so I'm seeing a lot of his post-op patients. Those tends to be LVP's, least valuable patients, because you only get the x-ray, but it's something that if you do surgery, you kind of have to do that. Next was a 71-year-old has left second metatarsal pain. Now this woman, she's didn't do really well with the foam rolling and shoe changes and things like that. She didn't want physical therapy, doesn't have time for all these things. I put her in a cam boot. So I put her in a cam boot to rest the area, and I said, hey, if it's not getting better in 3 weeks, we're going to do shockwave, because I really think that's what would work for her metatarsalgia. Next was a 33-year-old female, bilateral heel fissures. So for heel fissures, I did Cara 42% urea with the sleep socks, those gel socks. Now I find the more I'm explicit about how to use things, the more patients tend to take my recommendations with doing the socks and things like that. So I write it down. I want you to use the Cara cream once a day in the morning, and I want you to use the socks at night, and I prescribe it that way. I tend to find that reduces the patients like going elsewhere, because I explain how to use the actual products that we have. Next was a 78-year-old female. She's here. She has a really severe posterior tibial tendinitis and tendon dysfunction and flat foot and a prominent navicular tuberosity. And she already has bilateral AFOs, so we did the what are they called? One of the AFOs, kind of like the Ritchie brace, but it was hitting on that prominence. That's why I like the medial blaze AFO. It's a different company, but it has a little cutout where that navicular tuberosity is. So I had to heat that up and kind of mold it to her foot. We did get x-rays for her as well. Next was a 60-year-old female for right plantar fasciitis. After EPAT, she's 100% better, so no need for follow-up. She actually referred over her son to be seen by us. Next was a 48-year-old man. He was one of my Brazilian peeps. If you don't know, I speak Portuguese, and he found us online. He was previously taking diflucan maybe he just bought it in Brazil, and it didn't work, and he wanted laser, so we did the UV light shoe spray, ground them down to get the bulk off, and he's going to do 6 sessions of lunula. And then he also asked for terbinafine. I very rarely do this, but in this specific case I did, just because he failed the diflucan. And so this would be a most valuable patient for this, because he's doing laser and everything else. Next, I'm kind of going through another day. I'm going to go high points. 56-year-old female, number 6, 5 out of 6 for Achilles, starting to feel better. 66-year-old man, he had a left hallux wound at the distal tip. This was an MVP because he got the collagen kit. So the collagen is the Amerigel collagen. So we have to check with his insurance, things like that. Got x-rays, did debridement, and gave him the kit. And that reimburses quite well for those 2 weeks. One thing I was talking to one of the doctors that was here, when we do collagen, what I tend to do is those little packages, I tend to have them spray the saline in there, and they're kind of single-use packages. That's what they're really made for. So you have them sprayed in there, make it a gunk, and then you put it just on the ulcer. I tend to find that some patients they do a little bit of the collagen just to let it last longer, but realistically through insurances they can use one of those packages per day of the collagen powder. Next was a 65-year-old female for an ultrasound for plantar fasciitis, and we set up 3 shockwaves. And the reason she wanted 3 was because she travels 2 hours to see me. So we've been getting many patients from Western Mass, and there's really no podiatrists out there. For some reason they're finding us, maybe because of our SEO and stuff like that. But she got 3 sessions. I think we're going to do them every 2 weeks and see how she does with that. Next was another MVP, most valuable patient, 62-year-old female, wanted fungal laser, so we set up the fungal laser, and she got the UV light and the shoe spray. Next was an 80-year-old man. He had right Aquinas, and so we got the night splint foam rolling and morning stretch with the x-rays. Next was a 53-year-old female for right first MPJ pain. She's doing better with the orthotics, and she actually wanted a second pair, so this would be the second pair of orthotics. And just a reminder, when they come in for the orthotic follow-up, when they get the orthotics, they get a little flyer with the orthotic that says, hey, you bought these. If you want a second pair, it's $200 off the second pair, so you don't have to move them from shoe to shoe. And so that's why this patient asked for the second pair of orthotics. Next patient was a 68-year-old female. Plantar fasciitis was an MRI follow-up. Doing better, doesn't really want to do anything. I did didn't want to do much for that one. Next was an 80-year-old man for a right posterior tibial tendon dysfunction. And for him, I'm going to check on an AFO. I'm going to plan on doing an ultrasound at the next visit in 2 weeks. And also under the third med head, he has a very reduced fat pad, so we're scheduling him for Liposana because he's wanting to do hiking. And so that was his why. He wants to do hiking, so we're going to be scheduling that for him. Next was a 64-year-old female. We did brided an ulcer. 71-year-old man, second pair of orthotics, wants a second pair of orthotics. 62-year-old man for a right she had fungus and right ingrown toenail, so we did an IND for that patient. Next, 24-year-old man with a wart, we did cantharidin. So we'll see them back. Next was a 66-year-old man, flat foot, did orthotic number 2. So I'm sorry, orthotic number 2, meaning this is the second orthotic of the day. And this 66 man actually had prefabs first, and then when he came back, he liked them so much he wanted to do the custom orthotic. Next was a left metatarsalgia that's feeling better, but has fungus, so we started to treat the fungus. So if you see the kind of the tendency for me is when I'm seeing one thing, I'm always looking for the next thing. So a lot of times I'll add other things after I'm treating one condition, then I'll start treating the other condition. Or even when patients come back, many times we forget, like our staff are so well trained, anytime that someone comes in after they haven't been seen for a while, they'll even get new x-rays. So for a lot of these, you may be not doing the x-rays, but this just helps us because the staff automatically do all these x-rays. Next was a 61-year-old man that had a number 2 out of 6 for plantar fasciitis. So this one, since it was bilateral, I had the medical assistant help me to do that one, so that's been nice. Kind of speeds things up. Next was a 47-year-old man for a left Achilles. And I'm going to do an amnio trial, so I got some trial amnio from a company, so I'm going to be doing that, setting that patient up for that in a month. Next was the left fifth metatarsal fracture, doing shockwave number 3 out of 4. Actually, 5th digit fracture, number 3 out of 4. They're doing much better for this. Okay, this is a long one. I haven't done these for a while, so I think I'm going to take a break, and I'm going to come back and do some of these a little bit later. Once again, if you found these beneficial, great. Join Podiatry Practice Mastery. If you're not on my email list, you can go there. This is something I added recently. You can get the emails. I send out probably a weekly email, just some beneficial tips for your practice to get you to the $1 million mark and beyond. Okay, until next time, thanks.